Thanks, and welcome back, everybody, for another Australian neonatal webinar lecture. It's a pleasure to introduce Anke Raaijmakers. She's a neonatologist or pediatrician, originally trained in Leuven in Belgium, where she did her general training as pediatrics and then her side training into nephrology, and has then moved to Australia and is working at the Sydney Children's Hospital as a pediatric nephrologist. She will be the first of a series of lectures, which is going to happen in the next 2 months, about renal issues into our preterm infants. This topic, which is about long-term issues of acute kidney injury or just being born preterm, will be highlighted into sort of developmental studies, and further talks will be about AKI within the unit and sort of what can happen over there. But for today, welcome, Anke, and the floor is yours.
Thank you so much. I think this is the first time that actually someone pronounced my last name right, but it might be because we have the same heritage. My name is indeed Anke Raaijmakers. I am a pediatric nephrologist in Sydney, and I have a special interest in neonatal nephrology and long-term kidney health. And today I will try to guide you through the consequences of prematurity. And thank you, Julie and Kurt, for the invitation. I will try to limit my presentation to about 35-40 minutes, and then the floor is open for discussion. Happy to hear your thoughts on how we can do better. Thank you, Julie, for the title suggestion. So I think it sounds very catchy, but I will be mainly talking about the long-term issues of AKI and prematurity. One of the consequences is hypertension. So what to do when your babies or your adult patient blood pressure is higher than yours. So first of all, the main aim of my talk is to raise awareness on the long-term consequences of acute kidney injury and prematurity. So measuring a blood pressure should be routine practice, especially for kids born preterm and or with a history of AKI. There is one exception. If your child doesn't have any limbs, it's okay to not do a blood pressure, but I can't imagine any other reason not to measure. So preterms, especially those with a birth weight below 1.5 kilograms, but the lower the birth weight, the higher the risk, have an increased risk of chronic kidney disease and cardiovascular disease. But the recent Australian extreme preterm guidelines issued do not mention AKI as a risk factor, mention blood pressure once, and I think there is a lot of work to do to improve this for the long-term outcome of these children. This lecture is what Kurt already alluded to, an introduction to talks later in the year to reach neonatologists, but it's also very important passing the information on to pediatricians and GPs, but because I think this should be included in long-term follow-up of these infants, and I will try and show you why. So to further introduce the topic, I would like to discuss what is known about prematurity and development. So the formation of the definitive kidney starts, as you know, in the 5th week after conception with the formation of the ureteric bud. And since nephrogenesis lasts until approximately 34 weeks of gestation, it is rapidly ongoing and partly hindered in case of extreme preterm birth. There have been some studies that say that nephrogenesis might be ongoing after birth, after preterm birth, but those nephrons might be of poorer quality, and we think that there are definitely not as many formed after birth. So Barry Brenner was the first to describe a link between birth weight and low nephron number. And this lower nephron number will lead to a higher pressure in your glomeruli to get rid of your sodium, with subsequent functional nephron loss and hypertension. And this will be a vicious circle that might lead to chronic kidney disease. In case of prematurity, low birth weight and low gestational age will determine a lower nephron number. And in these preterm infants, the growth restriction often continues after birth, and the nephrogenesis after birth, as I already alluded to, might be suboptimal. Of course, The consequences of prematurity are not limited to the kidney. So Brenner focused on the lower nephron endowment in case of low birth weight in term infants. And Barker suggested that during fetal development, the consequences of genetic and environmental factors will determine health and disease in adulthood. He hypothesized that poor fetal nutrition leads to intrauterine growth restriction and subsequent low birth weight, with a higher risk to cardiovascular disease in adulthood. Of course, the Brenner concept is broader than the kidney, the Barker concept is broader than the cardiovascular system only, and this multi-organ concept is known as the developmental origins of health and disease concept. So early environmental influences will determine health and disease. If the mismatch is severe, teratogenesis might occur with perinatal death or the maldevelopment of organs. However, most children survive despite these suboptimal environmental influences like poor fetal nutrition and will adapt. So there will be no teratogenesis, but adaptations to these circumstances with short-term benefits, survival, but long-term consequences. In children with low birth weight, this will lead to intrauterine growth restriction and subsequent low birth weight, a higher risk to cardiovascular disease, and a lower nephron number. In case of preterm birth, we see this phenomenon of growth restriction mainly after birth, the so-called extrauterine growth restriction. Especially in low birth weight infants, the poor nutritional status is common after birth, and it is known that these children have a higher incidence of renal and cardiovascular diseases as well. There is also evidence that preterm birth itself increases the cardiovascular risk profile, and this is very likely due to nephrotoxins used in the NICU, infections, hemodynamic changes, AKI, multiple AKI episodes, and suboptimal nutrition or hydration. So if your patient has had neonatal acute kidney injury with or without prematurity, the risks are further increased, which I would like to discuss further in this part. Let's start with the definition of neonatal AKI. We mostly use serum creatinine as a marker, but you have to realize that creatinine is a relatively late marker, and it's a functional marker, not a marker of injury. So your GFR has to be reduced by about 50% before there is a creatinine elevation. And also it is a late marker because it only happens about 24 to 48 hours after an injury. The other important thing to notice is that you have to measure kidney function in some way, or you won't know that there is acute kidney injury. And I will show you later in this presentation that surveillance rates vary worldwide. There are different definitions used of AKI, and I will discuss the most common definition now. But it is important that you know which definition has been used when you compare different studies. And there are several downsides of creatinine. So there is a tubular secretion of creatinine. It is dependent on your muscle mass, it's dependent on your hydration status, and these maternal levels. So we know that the first couple of days of life, there is an interference with maternal creatinine, but beyond 24 hours, it is less clear what the effect of maternal levels are, but the first 24 hours, it's pretty clear that it's basically a copy of your maternal levels, plus or minus the kidney function of your neonate. So this is the KDIGO, the Kidney Disease Improving Global Outcomes definition. adapted to neonates. I'm not sure if everybody here is familiar with creatinine in micromoles per liter or in milligrams per deciliter, so I've included both. And here you see the different stages of AKI, where you can define AKI based on a absolute rise, a relative rise, and or urine output. So it's probably best to use a combination of all three, but there has been research that shows that the relative rise is actually even more important than the absolute rise. So in term infants, a normal creatinine rises somewhat in the first 24 to 36 hours after birth, subsequently decreases and stabilizes at about 35 micromoles per liter by day 5 of life, which is 0.3 milligrams per deciliter. In preterm infants, creatinine remains unchanged or even increases for the first 3 to 4 days, then slowly declines, reaching a steady state by 3 to 4 weeks of age. The most common definition you can see here, and I will use this definition further in my talk, and this is also the definition that is at the moment most commonly used in studies. What you can see here is a figure from the AWAKEN study. I hope that everybody here in the audience is familiar with the AWAKEN study. So the AWAKEN study is the assessment of worldwide acute kidney injury and epidemiology in neonates. It was a large study to investigate the impact of neonatal kidney injury, because up to 2013, AKI studies were mainly based on retrospective evidence, and the AWAKEN study showed that AKI is common and associated with morbidity and mortality. Most important morbidity markers were chronic lung disease, intraventricular hemorrhage, and length of stay. And the AWAKEN study showed that the prevalence is around 30%. So 1 in 3 neonates suffer from a variable degree of acute kidney injury. And they also showed several risk factors and the impact of neonatal AKI on those children. And they showed that it is an independent risk factor for morbidity and mortality. This is in the supplementary data from the AWAKEN study, but I think it's very important. So what you see here is that your serum creatinine count in your fourth column shows a correlation with your AKI rate. So that means that the more often you measure, the more often you will find AKI, which also means that if you don't measure creatinine, and there are some units worldwide that do not routinely measure serum creatinine, you don't know if there's AKI. And you also don't know that these kids might be at risk in the future. The AWAKEN study was already quite old. AWAKEN 2.0 is coming up, but this number of about 30% has been confirmed in a recent meta-analysis. It included 200 studies with 98,000 participants over 45 countries, and they came to the same incidence and conclusion. The incidence is around 30%, and there is a direct correlation with increased odds for mortality and morbidity. This meta-analysis also showed that there are similar rates across the world, and that this pooled AKI incidence is around 30%, and all stages have increased odds ratios for mortality. And yes, most neonates and most children have a normal blood pressure and a normal kidney function. But detecting clinical or subclinical kidney function decline is very important, and I will try to show you why. This is a very busy slide. It shows the results of the prevalence of kidney disease after preterm birth. And the important bit is here. up to 17% of preterms have CKD at the age of 2, and 1 in 5 have an elevated blood pressure. So why is this important? So birth cohorts around the world show the same thing, that chronic kidney disease is bad. A low birth weight increases your chronic kidney disease risk lifelong. And this table here shows an association, a direct correlation between birth weight as an infant and risk of chronic kidney disease as an adult, in line with what I showed you in the introduction, Brenner's hypothesis. More evidence that chronic kidney disease is bad. These graphs show the age standardized rates of death from any cause on the left, cardiovascular events in the middle, and hospitalization on your right, according to the GFR among over 1 million adults. So the lower your GFR, the higher your risk of death, of cardiovascular events, and of hospitalization. And this is, of course, a beautiful example of Bacchus' hypothesis. So what about our neonates? So these are different CKD rates in different populations, where neonates with comorbidities, AKI rates are very high, and these AKI rates will cause a higher risk of CKD later in life. So here are different birth cohorts with asphyxiated newborns on ECMO, congenital heart disease, the low birth weight infants, the very low birth weight infants. And all of them have different percentages of CKD rates. And not all of our preterms also have associated asphyxia or need ECMO or need multiple interventions. So these rates vary, of course, but the risk of chronic kidney disease is high in these premature infants or in the sick term neonates. Your risk of chronic kidney disease increases when you have AKI. So about 1 in 10 will have chronic kidney disease long term, but very good studies on the exact number of chronic kidney disease in long-term follow-up studies is a bit variable, as I showed you in the previous slide. Follow-up is variable, but it is there, and it might be as high as 1 in 10. So surveillance and long-term follow-up are of utmost importance to improve follow-up, early detection, and secondary prevention of chronic kidney disease. I'll start with detect early. So I've done a bit of research myself on the long-term outcomes of a subgroup of neonates, so the extremely low birth weight, as you know, the kids with a birth weight below 1 kilogram in early adolescence, and I found quite striking results, not only on neurodevelopment, as what we know, but also on kidney function and vasculature, and I will show you a few highlights. So here you can see that the eGFR, so the glomerular filtration rate of these children, is basically normal, but it is a standard deviation lower compared to healthy term-born controls. So there are early signs of renal dysfunction already present in children with a history of prematurity. And we showed the exact same for blood pressure. Most kids had a normal blood pressure. There were a few with hypertension, but the systolic blood pressure was about a standard deviation higher, and the kidney function is standard deviation lower. We also looked at the retinas, and I think that this is a brilliant topic for further research in the future, where we did retinal images of teenagers, and we showed that the cases compared to the control, so my colleagues who looked at these images and graded them were blinded if they were case or control, but they said that we could just see with our eyes what the difference was and which one were cases and which ones were controls. But we also used semi-automated software to analyze these vessels and to show signs of early cardiovascular dysfunction. And we showed that the vessels in former preterms were more, that there was more tortuosity, that there was arteriolar narrowing, which is an early sign of cardiovascular dysfunction, and less branching. And all these factors have been associated with an increased cardiovascular risk profile. We also looked at development. So we did a IQ proxy test and saw that the IQ of this birth cohort was also 1 standard deviation lower, but there was a direct correlation with this. So this CRAE is this arteriolar narrowing in your eye, and is a direct risk factor for cardiovascular disease. And there was a direct association between IQ and this retinal marker for cardiovascular disease. So what you see here is the blue ones are the controls, the red ones are the cases, and the darker shade is the overlap. So how can we prevent chronic kidney disease, and what are the recommendations for follow-up? If you ask me, can we prevent neonatal AKI? I must say yes, because this Baby Ninja initiative from a couple of years ago showed that we can prevent the use of nephrotoxic medications, that we can increase creatinine monitoring in certain neonates, and therefore improve outcomes. This study showed that pre and post-intervention rates of AKI dropped massively. So early intervention, pre-AKI, is key. And when we then talk about a follow-up plan, I think this is a great study and a great recommendation paper where my colleagues of the Neonatal Kidney Collaborative wrote a consensus statement on what to do with NICU graduates. And I hope that this will be included in the Australian follow-up guidelines in the future, but I will talk you through the important factors. So first of all, you need to do a risk stratification. You have patients at risk. Those are the ones that are born preterm, that have early stages of AKI, or have critical cardiac disease without AKI. And then you have your children high risk. So those are the extreme preterms, born before 28 weeks of gestation with a birth weight below 1.5 kilos, or who had severe AKI, or the critical infants without prematurity with a history of AKI that needed dialysis or close, recurrent episodes of AKI, or any severe non-kidney comorbidity like ECMO. Infants with critical cardiac disease, they split it up in a separate column with children who had cardiac disease with some complications. So stage 2-3 AKI with only a single ventricle, with a heart transplant with associated HIE, or prematurity, who have been on ECMO or had nephrotoxic medications at discharge. This is their table. So they split, I'm not sure if you can read from there, but you have 3 columns of preterm infants, critically ill infants with AKI, and infants with critical cardiac disease. And the first thing I would like to point out is this: evidence of ongoing kidney disease. So I had a discussion very recently in the NICU here at the Royal Hospital for Women about a normal creatinine in babies. So here in the consensus statement, they say if the serum creatinine is over 0.5 milligrams per deciliter, there is evidence of ongoing kidney disease. And I'm not sure if you're good at maths, I'm not so much, but that's 44 millimoles per liter. So that means that your children with a creatinine of 44, which is normal limits if you look at our hospital charts, that they have evidence of ongoing kidney disease. For a preterm with a birth weight of, let's say, a kilo or a kilo and a half, a normal creatinine should be around 15 and not 44. So I think we need to readjust our normal values and take them into account whether or not there is evidence of ongoing kidney disease. Of course, when blood pressures are high, when there is hypertension that needs treatment with medications, if there's nephrocalcinosis or associated kidney abnormalities, it is recommended that you talk to your local pediatric nephrologist for further follow-up. So this is the risk stratification that we talked about for these 3 different groups. And the recommendations are a little bit different for at-risk kids and high-risk kids. This is something that I think is the most important of the whole paper, and it says discharge, kidney education, and health evaluation. So to do a creatinine at discharge, to do a blood pressure, and to make sure that the family and the clinicians who will follow this baby up are educated about the kidney health of these infants. So then they recommend to do a comprehensive kidney health assessment at 6 months of age, see if there were any significant additional exposures or risk factors, and to continue kidney education and a comprehensive kidney health assessment at the age of 2. And before you say, where's the blood pressure, they recommend a blood pressure at all health encounters. So this is the big table again, focusing on the last bit now. So the follow-up during childhood, depending on this 2-year evaluation of and risk of future kidney health. So most centers, including ours, recommend a yearly blood pressure and a yearly UA for protein loss. If there is some protein loss, an early morning albumin-creatinine ratio can be helpful, in line with this evidence of ongoing kidney disease, where you can speak to your local team on follow-up of these high-risk babies. This slide I wanted to show because I think we as pediatricians have an important intervention window for our babies. So early interventions are needed to minimize risk factors and consequences later in life. And we have the ideal window because when we intervene, we can prevent cardiovascular risk factors later in life and do both primary as well as secondary prevention. So it brings me already by my take-home messages. So what do you need to consider? What do you need to consider for these babies? An assessment of risk factors and measuring of blood pressure should be one of the elements of screening for all neonates and children, at growth and development checks, at GP checks or subsequent pediatrician visits. And if there is any hypertension or other risk factors, a first morning urine sample to assess for proteinuria would be beneficial. And there is a bit of debate on how often and what to test and what strategies to disease progression are necessary. But if we don't measure and if we don't hand over, we won't know. Which brings me to the second point, the counseling bit. So the awareness must increase, and it starts with the NICU graduates. It starts with the neonatologists talking to parents about the importance of follow-up, and not only the growth and development check, but also to focus on the increased cardiovascular risk profile of these children. And I hope that in the next version of the follow-up guidelines of preterms, this long-term awareness and screening of cardiovascular risk factors will be included. And importantly, there are lots of studies done that AKI episodes sometimes not even make it into the discharge summary. So hand over to your colleagues who do the growth and development clinics, to your pediatricians who look after these babies, to GPs who receive letters about the importance of renal and cardiovascular follow-up is highly recommended. I must have talked very fast because this is my last slide. I'm very happy to discuss this further and take any questions.
Thank you, Anke. There was a very nice overview about how important, yeah, particularly a preterm, but also our sick population, have, one of the organs which also need to be followed, which is the kidneys. You took us to definitions, which is always a really good start, and I really everybody should read that Awaken study, what it all comes from. They sat down, made the definition, and worked with that one first. And then, of course, they had some adjustments thereafter, but it's important to begin with the definition. You told us some numbers which were actually, really high, about AKI either in the NICU and during follow-up, and the importance of risk assessment at discharge. I thought that was a really good one, just a risk assessment at discharge, and then, sending these babies for follow-up. And I think just the realization, say you were 1,000 grams in the 60s, there's just 1 in 10 survivors, and these patients would now be 65, the age where you normally develop chronic kidney disease or beyond. And now we have, 9 or 9.5 out of 10 of these babies will survive. So we don't even know yet what is yet to follow for our adult colleagues who's going to treat AKI and particularly chronic kidney disease in the future. All right, there's a couple of, we have lots of time, and I certainly have a lot of questions, Anke, but we start with Samil. He has about, are there any alternate markers, biomarkers, or any other kind of markers where we can look during the NICU for this kind of risk assessments or assessing AKI?
Yeah, that's a very good question. I think in the lecture topics later in the year, this will be further discussed, but I think the most promising one is urinary NGAL. So that is a marker of injury, which is already a very big advantage compared to creatinine because creatinine is late and NGAL is early. So it's NGAL. You can measure it in the urine, which is also non-invasive, and there are these lovely techniques of catching baby's urine, which you guys are much better at than me, and detecting this early. So I think that's a great marker. There have been some studies about cystatin C, that is a serum marker, can also be tested in the urine, but most studies use it in serum as an alternative for creatinine. The problem with cystatin C is that it's great, and I actually have done some studies about cystatin C, and especially in these preterm infants where the body composition is different, so your muscle mass is different from your healthy controls. So cystatin C might be more reliable. It's just that, is your lab trained enough to do this? Do you have access to cystatin C? What's the turnaround time? Which test do they use? Because there are different ways of measuring, for example, cystatin C. So you need to work with what you've got. And I think creatinine worldwide is still the most available marker. Will this change in the future? Very likely, because there are beautiful studies about NGAL showing early signs of kidney injury. And I'm sure that David Zalewski, who is on the list, and I've recommended to Kurt and Julie to invite him because he's an amazing speaker on this topic. So I really don't want to already spill the beans, but it is an early marker where you can decide, does this baby need fluids? Or are we already down the track of AKI, and do we actually need to cut down fluids? So you can actually use it in your clinical decision making where you are in your stages of AKI and what your intervention might be. The other topic are different acronyms and different elements of kidney function that you can use. So what you will hear as well, and what what I completely agree with is, what blood pressure do you need? So what is your target blood pressure for your babies when you use inotropes, for example? I think the answer should be when you have adequate urine output. So if your blood pressure is targeted at a MAP of 50 and you don't have urine output, and you target 75 and you have good urine output, then that's your target. If you can meet that requirement with a MAP of 25, great. That's perfect. But you need to take into account all these different things when you measure kidney function and when you make a diagnosis of AKI.
Thank you. The Peach Group in Sutherland, they looked carefully at your prevalence data, and they noted that AKI was higher in the term infants than, say, 26, or than, say, late, than preterm infants. Is that true? Or is it just a highly selection of data?
It was so in the Awaken study. There is indeed. So if you, yeah, I can go back. But so if you look at the incidences, it is a bit skewed because your term infants are usually not admitted to the NICU. So in the Awaken study, you had to be on fluids for 48 hours. So that means if a baby needs to be on fluids for 48 hours, you will get your sicker infants. So it might be that those rates are slightly different. So a healthy preterm compared to a sick term, so a term baby with cardiac disease, with acute illness, with hemodynamic instability, that baby has a higher risk of AKI compared to your preterm healthy infant that is otherwise tracking along. So I think that's the difference there.
All right. There's another question about prevalence, and maybe in new data or sort of a follow-up from the Awaken or your own experience. We've been using less NSAIDs. So do you notice a change in prevalence of AKI in the very preem infants because of this?
Yes, very good question. So the birth cohort that I studied myself was a birth cohort born 2000 to 2005. And we did a study on, so ibuprofen was used to close PDA in that era. So all these babies who had a PDA got a patent ductus arteriosus for, but I assume that people are familiar with this term. So we looked at children who got ibuprofen and not. So as I showed you, the kidney function in teenagers is one standard deviation lower compared to controls, but there was zero difference on the ones who got NSAIDs or not. So ibuprofen or not, they were bang on the same. So we couldn't show that early ibuprofen use, we only used ibuprofen, so early ibuprofen use did not impact long-term kidney function. Of course, the more nephrotoxins you use, the more risk you have at kidney function decline. But I haven't seen a trend down because we changed and managed our PDAs differently. What I would like to say is that your caffeine, so caffeine is routinely used, and I'm sure that my American colleagues will talk about this too, but so caffeine is routinely used in many units in Australia, and I think that's why we see slightly lower AKI rates. So this 30% is worldwide, but Australia comes lower. So Australia is lower. It's like 20%, and I think it's because of the standard use of caffeine.
You always have the question.
The question actually, because I deviated.
No, that's all right. There's a couple more questions, so I think we'll go on. We can get back to it a little bit later. Yogesh has a good question. It's about these kids, they're 2 years old, and you have to measure the blood pressure, which can be tricky. Maybe you have some tips for that. And on top of that, and that's also in the adult world, blood or hypertension is not diagnosed on a single measurement. What should we do in these groups of babies?
Yeah, very good question. So as a nephrologist, I get consults for hypertension all the time. And my first question is, how did you measure? What was your cuff size? And was the baby settled? So if your child is screaming your consultation room down, then that's not the ideal way of measuring a blood pressure. You need to have an appropriate cuff. So I usually use my own, like your cuff needs to cover 2/3 of your upper arm at least. If you can choose between the neonatal one and the kids one, try the bigger cuff because that gives you a more reliable blood pressure. I sing songs in my clinic to calm the babies down and the children to measure blood pressures. So there are lots of you have to do it. You have to do it frequently. It needs to be part of your routine practice, and then you will get better at it. But one important comment that I want to make is that we have in pediatric nephrology, we were ignorant on hypertension for a long time because of normal office blood pressures. So white coat hypertension, everybody is familiar with. Okay, you have a high blood pressure when you're seeing a doctor, but when you're out of the hospital, your blood pressure is normal. But a lot of these children have masked hypertension. So masked, as in a mask, masked hypertension is a blood pressure that is high in the community or at home and normal in your office. The best way to diagnose hypertension is with a 24-hour blood pressure monitor. It's very difficult in children. We use it from 6, 7 years of age. But sometimes your kids with multiple risk factors, delayed development, it's tricky. I sometimes teach parents to do blood pressures at home. And especially the slightly older children, like the 8, 9-year-olds, you can perfectly use the small adult cuff, check what the blood pressure is on the machine, check it with your own blood pressure in clinic and see if it correlates, and it will give you an idea. And you have more values, so more chances to diagnose hypertension, and it will be more reliable.
So how many blood pressures do you need to start treatment?
Yeah, so we usually say on 2 different occasions, I think it's 6 months apart in the newest guidelines. I don't wait with that if there is proteinuria. So you can start treatment early when there's proteinuria and minimal or no hypertension. So in the children where there is proteinuria, I start early, and in the hypertension guidelines, you need to do lifestyle changes, etc., before you start medical treatment. Of course, that's important. And salt is a very important factor. So I give salt education in most of my clinics for kids with a high blood pressure. The difficulty with preterm kids is that those parents struggled for them to gain weight for a couple of years, and then all of a sudden they gain too much, or they have high visceral fat, their body composition is different, in line with the Barker hypothesis that I talked about. So in theory, you need to wait, but I try to, when I diagnose it on definitely 2 occasions, then I just start treatment, especially when there's proteinuria.
And then, this is the key question, are there any randomized longitudinal studies which show that is better?
Yeah, so if you limit your proteinuria and if you lower your blood pressure, so it's recommended for children with chronic kidney disease that if you target your 50th percentile, so for the general population, it's below the 95th percentile, but there are studies that show that if you target a 50th percentile for especially the children with chronic kidney disease, that's actually better and beneficial. And for proteinuria, it is shown that if you treat your proteinuria and your hypertension, you slow down kidney function decline. And I think that's what's key here. Most of those children have a fairly normal or slightly lower nephron number, which can get them through life. But only if you manage your blood pressure and if you manage your proteinuria early on. So if these children are lost to follow-up and they now present at age 60 with chronic kidney disease and end-stage renal failure, I think that's partly on us because we didn't counsel them that that's important. We don't see these kids, we don't see these adults, But there is a lot of literature that if you treat your hypertension and if you treat your proteinuria, most of those studies are adult studies, that it slows down and improves your long-term cardiovascular outcomes.
Adrian has a question, which you pointed a little bit on it. It was about this kidney education, but what is kidney education, and are there useful resources, particularly for parents, to sort of help us remember what
Yeah.
it is we actually looking for?
Yeah, excellent. Very good question. So I'm at the moment together with Alison Kent, one of the neonatologists who did a lot of research on this topic. I'm working on information leaflets for parents, for pediatricians, and for neonatologists. Kidney Health Australia has some nice resources, but those are focused on kidney disease and not really the preterm infants. So I think the bottom line of kidney education is that those kidneys have had a hit by being born preterm and or having had kidney injury, and that to look after those nephrons and these kidneys, monitoring and follow up is important, and a yearly blood pressure check and a yearly urine check is probably enough. We don't have evidence that it needs to happen more often, and a lot of these kids don't have any issues in childhood. So when they hit puberty, sometimes I do, in kids with high risk, I do a blood test as well, but usually I do a blood pressure and urine only, and do a baseline kidney function test at the start of puberty to see where we are at. So kidney education is telling these parents and your colleague pediatricians that the kidneys are, as well as the brain and the lungs and the eyes and the cardiovascular system, the gut, all affected by prematurity, and kidneys do not show when they're under stress. They will only show symptoms when it's late, so prevention is key.
About follow-up and what measurements, you told the series of tests. Do you use ultrasound in the follow-up as well, or is that selected groups?
Yeah, so ultrasound is mainly used for congenital abnormalities of the kidney and urinary tract. I do not use routine ultrasound in these babies. Most of the ultrasound studies done in research settings show that these kidneys are relatively small, but most of these kids are relatively small, so they're probably like age appropriate. So the problem is, and that will be the million-dollar question, we can't measure nephron number. So there is a huge variability between your nephron number and mine. I don't know my nephron number. We know that one kidney contains about 800,000 nephrons. But you can also have 400,000, or you can have 1.3 million. And that variability is huge. We don't know if this preterm baby was born with 400,000 nephrons or 200,000 or 1 million. So size, there is a little correlation between size of the kidney and nephron number, but it's not great. And we can't measure nephron number. So ultrasound, in case of dilatation, in case of congenital abnormalities, yes, it has a value. It is nice to see that these kidneys are growing, but it's not changing your management. So I don't routinely do ultrasounds in these children. I usually do one at baseline, and I do another one a couple of years later to see that these kidneys are appropriately growing, but the benefit of ultrasound is limited.
All right. Thank you. So, Sripada has a question about preventive strategies, because actually much of the stuff you're telling here is about prevention. And you already told that Ninja project. I Googled it. That looked awesome. So, can you tell a bit more about preventive? This audience will be predominantly neonatologists. What can we do?
Measure routinely creatinines. So involve your pharmacists involve, so to do proper prevention studies and to do quality improvement projects in your unit, you need a keen nephrologist. Very happy that you reach out to me anytime if you need advice on that. You need to inform your neonatologist that you're going to try and reduce AKI or long-term kidney issues in your unit. You need to measure creatinine routinely and not consult your nephrologist only when the creatinine has quadrupled, but maybe consider when these babies are slightly fluid overloaded. But this will come back in the later talks. So I think a like neonatal nephrology ward round, like you do with your infectious diseases, for example, can be very beneficial, that you talk with your local pediatric nephrology team, like how can we do better? When you use nephrotoxins, Australia is a very gentamicin country, so it's used often. When you use nephrotoxins, to be mindful of the kidney function and measure it more often, to look at your fluid balance to see if the urine output is still there, to detect acute kidney injury early and to support your kidneys as best as you can. And that can sometimes concentrate feeds, reduce fluids, reduce infusions, concentrate infusions, that kind of stuff to support the kidneys. But it also is important. So in the NICU phase, it's important. In the handover phase, it's important. And then your strategies longer term. So for kids at risk, I counsel parents to try and stay away from, for example, ibuprofen, and to choose paracetamol for pain or for discomfort, to hydrate well, to be mindful of salt intake, lots of exercise, very important, avoid obesity, avoid other cardiovascular risk factors like smoking, vaping, I can talk about for hours because I think that's terrible, those things. But so different phases require different interventions. I hope that makes sense.
Yeah. Sort of a follow-up question from Celia. If you use gentamicin and you do those creatinine measures, do you see those changes in creatinine or?
Yes. So if you do, so I think the first thing is, if there is AKI and you need your gentamicin for a clinical indication, to adjust your dose. So to give a lower dose in children with acute kidney injury to make sure that you don't get toxic gentamicin levels. For gentamicin, we can do levels, so we can do therapeutic drug monitoring. And when you give a dose of gent, your creatinine shoots up for everybody. But if you start with a creatinine of 10 and it goes up to 35, then that is actually already tripling your creatinine. So you already have a stage 2 AKI that nobody will realize because it's still within the normal values. So really looking at those values, looking at fluid balance, looking at urine output and at creatinine will be beneficial for these kids.
All right. I think the last question is about, what, you as a nephrologist. I think there's only, I don't know, 10 in New South Wales, maybe less. But you did suggest the high-risk babies, which is 28 weeks and below, and 1,500 grams and below, which is hundreds.
Yeah.
So I guess, a step forward would be indeed the follow-up and the developmental specialist to be part of this education and follow-up, because I can imagine referral to the nephrologist of all these high-risk patients is logistically not feasible. What do you say to that?
Yeah, so I can't see them all. I think there are these lovely projects in low resource settings where there is like a satellite hospital that does telehealth and education in different centers. And I was part of one of these lecture series, I think, and that was amazing. So I think a way of educating clinicians, it's not rocket science what I do. Measuring a blood pressure is not hard. Okay, it can be challenging for some children, but it is the awareness that's key. And we manage children with slightly higher blood pressures, with proteinuria. We manage them remotely. We talk to the local pediatrician, and they ask us for advice if they need it. And so I think to educate it starts with the GPs, because there are so many ex-preterms out there
Mhm.
that are now 40, 50, 60 years old. Like, of course I can't see them, because I'm limited by the hospital. I can't see anyone over 18. So I think education is key, and not all of these kids have to see a pediatric nephrologist. But if they are part of neonatal ward rounds, and if they are part of education sessions, and if they're part of developing leaflets and education to neonatologists, I think it starts there.
Look, that's probably why the AWARE study is called the way it was, isn't it? Or was the AWAKEN, but it might be called the AWARE study as well. Look, Anke, it's 2 o'clock. Thank you so much
Yeah.
for presenting us. We picked up a really, really nice set of ideas, particularly singing to your patients when you do
Yeah.
a blood pressure. There was an ophthalmologist here. We did exactly, or recommended exactly the same. So that's something we can incorporate immediately. Thanks all for attending again and for being part of this discussion. I'm not sure about next week's, but we certainly have a new webinar in 2 weeks. Thanks all, and see you all next time. Thanks, Anke.
Pleasure. Bye.